Good morning, everyone, and welcome. I'm Alice Buffkin, Director of Policy for Child and Adolescent Health at Citizens Committee for Children. Before we begin, please note that closed captioning is available this morning if you should need it. I want to welcome you all to the third of 5 R.E.A.L Talks in the month of October. R.E.A.L Talks is a collaboration among Citizens Committee for Children, FPWA, and United Neighborhood Houses that grew out of a desire to confront and address the ways racism harms families and communities in our city and our state. The recent and senseless killings of George Floyd, Breonna Taylor, Daniel Prude, and too many others is part of a long history of violence against Black and Brown communities. This violence is itself a symptom of deeply entrenched racial inequities and injustices that permeate the systems that serve children and families in New York every day. Similarly, the way that COVID-19 has devastated Black and Brown communities is no accident. It's a product of decades and centuries of policies, laws, and practices that have impacted Black, Brown, low-income, and immigrant communities, making them most susceptible to this pandemic and all of its associated harms. R.E.A.L Talk aims to bring attention to these types of systemic barriers and to generate discussion on how we can challenge them and achieve real equity. During today's panel, we want to focus on an important and often underlooked aspect of the twin pandemics of COVID-19 and systemic racism, their effect on the mental health and well-being of children and adolescents. Even prior to this pandemic, New York was facing a crisis in children's behavioral health. Suicide is the second leading cause of death for children aged 15 to 19, and the third leading cause of death for children 5 to 14 in New York. In recent years, we've seen an increase in suicidal behavior among youth in general, among Black youth in particular. Children without access to appropriate behavioral health supports are often left on wait lists or churned through a revolving door of hospitalizations and crisis interventions, too often experiencing greater illness as they grow into adulthood. We know the kinds of trauma caused by COVID-19, including loss of loved ones, housing instability, economic insecurity, hunger, severe disruptions in learning, and social isolation, can have long-lasting repercussions across the health and well-being of children as they become adults. Like all the other aspects of this pandemic, the mental toll of COVID-19 has fallen disproportionately on Black, Brown, immigrant, and working class communities. In the face of these challenges, we know that New York is filled with parents, advocates, teachers, health and behavioral health care providers who are fighting every day to make life better for children and families. Many of them are listening on this webinar, and we thank you for your work. We are joined today by 3 incredible advocates who I'm very pleased to introduce. Dr. Jennifer Havens is Vice Chair for Clinical Integration and Mentoring at the Department of Child and Adolescent Psychiatry at NYU Langone Health. She is also Director of Child and Adolescent Behavioral Health at NYC Health and Hospitals, and a professor in the Department of Child and Adolescent Psychiatry at NYU Grossman School of Medicine. Dr. Warren Ng is the Medical Director of Outpatient Behavioral Health and the Director of Clinical Services for the Division of Child and Adolescent Psychiatry at Columbia University Medical Center and New York Presbyterian Morgan Stanley Children's Hospital. Dr. Ng is also President-elect for the American Academy of Child and Adolescent Psychiatry. And Dr. Erin Relaford is the Child and Adolescent Psychiatry Fellowship Training Director and Clinical Assistant Professor of the Department of Child and Adolescent Psychiatry at NYU Grossman School of Medicine. He's also the Associate Medical Director and Director of Child and Adolescent Psychiatry at the Family Health Centers at NYU Langone, Brooklyn, and Sunset Terrace. If you follow the link in the chat, you can see additional biographical information about our guests. I want to welcome Dr. Havens, Dr. Ng, and Dr. Relaford. We're so pleased that you're able to join us today. We're actually going to dive right in with a series of discussion questions for our panelists. So I want to start by returning to some of the key issues I raised in my introductory comments. Children from Black and Brown communities across New York City are experiencing heightened trauma, both from the effects of COVID-19 and from racism experienced not just in policing, but across systems. Can you talk about the ways you're seeing this trauma manifest for the children you serve and why it's so important to address? And Dr. Havens, let's start with you. And Dr. Havens, you're muted right now.
Okay. Thanks, Alice. Great to be here, and thank you and CCC and your partners for highlighting these really crucial issues. I was just going to start with a little bit more detail on what you described so articulately in your introduction, which is how big is this problem and how specific is this problem to Black and Brown communities. A couple of weeks ago, the United Hospital Fund released a wonderful report. It's not wonderful, it's actually terrifying, but really important report called The R.E.A.L Effect, talking about the effect on COVID in kids and families across New York State. And if we can see the first slide, please.
We're going to have that slide up in just a moment. And if folks want to look in the chat, you can actually see the link to the full report.
Yeah, so I want, first of all, thank you. First slide, please. That's the second slide. Carlos. Yes, so first of all, I want to thank Suzanne Budridge and Christine Ramos-Galan, who did this amazing work in consultation with a pro bono group from Boston. And this was building on a report they'd done on the effects of opioids on kids. Next slide. So this is between, just please note, this is between March and July. So this is not now, this was the first 5 months of the pandemic. And they projected that 4,200 kids living in New York State would lose a parent or a guardian to COVID. The majority of them around New York City and 57% of them in the Bronx, Brooklyn, or Queens. But I do want to point out, when you look at this map, other urban areas across New York have been also hard hit. Next slide. When they looked at this on a population level, it turns out that 1 in 1,000 New York State kids has lost a parent to, or a guardian to COVID. And you can see below on the slide how it compares to the same to death rates for other kinds of illnesses in the same period. Quite striking. When they broke it down by race and ethnicity, it turns out that 1 in 600 Black or African American kids lost a parent or guardian, 1 in 700 Hispanic kids, 1 in 1,400 Asian kids, and 1 in 1,500 Latino kids. So again, seeing the impact specifically on Black and brown kids. Next slide. Now, this is an unusual crisis, like nothing we've seen before. You can see the unemployment rates on the top of the first graph. 40% of low-income workers have lost their jobs through the United States, unlike other recessions, which have affected high-wage earners and low-wage earners relatively equally. This is really concentrated among low-wage earners. And 2.6 students in New York State, million students, are affected by educational challenges in this epidemic. Next slide. This is more than 1 million children have been affected by parental job loss. We don't have good information about undocumented workers because we don't track them. But the estimates of the United Hospital Fund reported that 325,000 children in New York State will go into poverty, secondary to COVID job losses. Next slide. And what does that mean? That means they're at risk for eviction. There's food insecurity and malnutrition, loss of health insurance, and difficulties with remote schooling, i.e. the digital divide. So we have a pandemic that is raging through our country, affecting all of us. But as is typically the case with pandemics, hitting the most vulnerable at baseline the hardest. So kids who don't have great access to mental health services to begin with in their communities, who are living with racial, economic, and educational stress at baseline, now doing even worse in a time we are really looking at very significant budgetary problems. So that's unfortunately sobering, but that is the context, and we're going to go on to talk about this more with you.
Thank you, Dr. Havens. Yeah, I mean, clearly really sobering information. And again, I do encourage folks to take a look on the link on the side if you'd like to see the full report. You know, that's really helpful context. I want to turn to Dr. Relaford now. Can you speak to your work supporting families affected both by COVID and by racial injustice more broadly?
Sure. Thanks again. I was really happy to be here. I think that supporting families and children and adolescents who are dealing with this, I mean, it starts with engagement, right? Sort of, Dr. Havens just talked about the lack of access to mental health care, particularly for minority communities, is a real challenge. That makes it hard to actually access care. Decreased insurance rates, not having a primary medical care doctor, stigma within the communities in which the medical providers aren't really necessarily aware of that prevents them from engaging and contributes to increasing rates of mental health concerns in these minority communities. And then you add on the poverty aspects, in terms of contributing to social determinants of health, lack of housing, appropriately food insecurity, et cetera, that contributes to that. But then you add on another factor, another stressor, which is sort of the lived experience of systemic racism. On the one hand, while it's really powerful for a lot of youth and families who are engaging in sort of protests in regards to issues of police brutality, it also, on some level, serves as a re-traumatization because you're faced with the fact that because of who you are, because of the color of your skin, that you, on some level, are subject to violence or potential violence. And that's an extra added stressor. And what we know is that independently, these challenges with social determinants of health, as well as mental health disparities, are contributing to increased mental health challenges. But adding on more stressors that are race-based certainly will contribute to increased anxiety and depression. On top of that, the traditional community resources that are typically there, particularly in the Black community, in the church, for example, can't access. I mean, these support and coping mechanisms are closed off because of social distancing and quarantine. And so it makes it challenging for these families to engage with others to actually deal with these things, which are traditional mechanisms to battle some of these stressors. So I would say that minorities are uniquely vulnerable and even more vulnerable than others because they can't escape and they can't get away from these realities.
Thank you for laying that out. I think those are really important points to keep in mind. I want to turn to Dr. Ng now. Are there other aspects of what you're seeing on the ground that you would like to address in addition to what Dr. Havens and Dr. Relaford have spoken to?
Thank you, Allison. It's a real pleasure to be here, and thank you, CCC, for sponsoring this incredibly important dialogue. I think echoing the wisdom of Dr. Havens and Dr. Relaford before me, I think this is racism as well as mental health are additional pandemics on top of what we're currently experiencing. I do want to highlight some resources that might be helpful in illuminating our discussion and facilitating further learning. There's a lecture series from the American Academy of Child and Adolescent Psychiatry addressing similar issues called Improving Health Equity during COVID, looking at systems of care, religion, African American experiences, schools, and racism in training. I think that these are incredibly important times, but it's also really important for us to appreciate the context in which we're living, but also how mental health plays into that in a really important way. In addition to the two pandemics currently of COVID-19 and racism, racism is a determinant of health and mental health, and racialized trauma compounds, as you heard from Dr. Relaford, the additional stressors that you've played out very nicely, Alice, in really opening up this dialogue. One of the things that we really appreciate in this context is also that children and adolescents are sponges. They absorb everything in their environment. That could be the emotional distress and experience of their parents and their family members, but also with regards to the air, the water they take in, but also their messages that they receive that are inherently either through systemic or institutional racism. So one of the things that we appreciate is that children at this time, looking at different surveys, 25% of them in one survey responded as being anxious, 35% were scared, and 19% were feeling helpless. And when we look at other studies looking at PTSD and post-traumatic stress disorder, isolation and quarantine has had an impact on children and how they experience themselves. But if we understand the context of 1 in 5 children and adolescents have a behavioral health condition, and that 50% of all adult mental health conditions begin before the age of 14, we're really looking at a very important population to focus on. Echoing Dr. Haven's comments, really, how can we focus more on children and adolescents, knowing that they're experiencing this? Health access is huge. Immunizations have decreased dramatically within New York State. I think in the early spring, it dropped by about 95% in April, and it's only increased to about 65% of its baseline. And that's a real concern. How do we understand immunizations? What information are we getting about health that is influencing how we understand getting help? Schools, which are our traditional representative of shelter, food, education, and social emotional learning, has also been a real challenge for our families. So understanding the impact on parents within homes and how children are affected by that when parents are trying to work as well as take care of kids, as well as take care of themselves. You don't have that safety and sanctuary that we had before. And as a result of that, we understand that child abuse reporting, and many of these reports are made by adults, not always within the home. So schools represent a significant part of that, but there have been a 51% decrease in child abuse reportings within New York City in May of this year. And those calls have continued to be declined. I think with going back to school, we'll definitely see how that is affected. The other thing is that what was notable about those child abuse reports was that a quarter of those reports involved substance use or alcohol among the adults or the parents or the caregivers. It's also representing the other pandemics that are going on, not only for children and adolescents, but also for adults, parents, and caregivers. We're also experiencing a spike in domestic violence, which increased in the New York State in March of 15% and then 30% in April. And we're also seeing families in stress, as Dr. Relaford very clearly pointed out. But when we look at some of the CDC MMR reports in August, looking at the disproportional impact that this pandemic has had on Black and Brown folks and families, it's very striking. Half of all Black or Hispanic identified individuals to a national survey for adults reported that they were experiencing significant adverse mental health effects, and also there had been a 25% increase in substance use in the last 30 days, or increased or new use within the last 30 days of young adults, which really warrants sort of more attention. You highlighted many important issues with regards to hunger, but I also wanted to highlight the immigration stress on many of our Black and Brown families and the sort of the fear that they live with every day. So that's a larger context, and I think just acknowledging that all of these play into the experience of mental health, as well as the healthy development of children and adolescents. And when we think about the adverse childhood experiences and the ACEs, and how we understand children's trajectory for their health, mental health, as well as their success in life, all of these are predicted by many of the factors that you highlighted, Alice. So I really appreciate this dialogue. Thank you.
Thank you, Dr. Ng. And I'm really glad you brought up the issue of the number of children, the percent of children who with a mental health condition are identified before age 14, because I think that really draws attention to something I think we all know, which is the importance of getting to children and their families as early as possible, prevention, providing as many supports across all the social determinants of health as we can. So we've talked a lot about some of the challenges facing children and families. I want to turn now to a discussion of behavioral health interventions, programs, and approaches that you think are important for addressing trauma and improving health and behavioral health outcomes. And Dr. Ng, I'm going to stick with you and see if you could speak to your experience working with communities and families in Washington Heights, including through home and school-based care.
Thank you, Alice. And I'm definitely, thank you, Alice. I really appreciate that. And also, I know Dr. Haven's really speaking broadly for what's happening in the city, and Dr. Relaford will add to this. But I have the privilege of working in Washington Heights, northern Manhattan. It's a rich community of color as well as culture. And it's really appreciating our communities in which we can actually have appropriate and impactful interventions. Within our community in northern Manhattan, 72% of our population is Latino identified, 7% Black. Half of them are born out of the United States, but 37% limited English proficiency, with 20% of our families living in poverty and 53% affected by rent burden. So I think one of the things that's also important, numbers don't tell the story. It doesn't tell the story of the richness, but also the resilience within communities. So I think it's really being just mindful of what we're doing. So a lot of the services that we've tried to develop in Northern Manhattan have really been to try to understand and respect those in terms of bringing services ideally to where the children are. I think we have to move beyond the idea of making children and families come to clinics or other places outside of their natural environment, because I think one of the issues that we play out is really stigma, as well as really the additional burdens on Black and Brown families in accessing care when many of them have to do many other things that are important in maintaining their families. So looking at a family through a cultural lens of language as well as culture is really important. And Dr. Relaford mentioned also the faith-based integration, and it's really important to be understanding of all of the resilience. Having bicultural, bilingual providers is really key. So before COVID, a lot of the things that we did was provide home-based services through one of our crisis programs. And that really gave us a unique opportunity to work within the home, to really work with the caregivers that are taking care of the children, because sometimes the people who bring the kids to the appointments are not the ones spending all the time with them at home. And really understanding with the abuelas and our grandmothers, titis and aunts, how do we understand really a meaningful impact? The other thing is that not all families are really able to access some of the digital sort of online access in terms of telepsychiatry, which has been really dramatic in terms of what we can do. But the other things I want to go back to is really going to where the kids are. They're in schools. How can we create a more healthy, mentally healthy learning environment for children? And part of that is partnership with parents as well as with teachers. And I think during this time, we've actually launched a daily parent and teacher support line at 2 o'clock every day in English and Spanish, really to provide additional support for our community, because we know that at this time there's a lot of stress with parents in navigating all of these things. And then primary care, most of the behavioral health interventions occur within the pediatric office. There's trust, there's a relationship that you want to build from, and those are things that are really important. And half of all pediatric visits really involve a behavioral health component, so it's really important to acknowledge the strength of that. But I think going back to just telepsychiatry, which we pivoted all of our services primarily to, that's not always easy. Many of our families live in overcrowded situations where I would say that our office or for therapy has turned into the toilet Zoom or the bathroom where you can actually close the door and have a dialogue. But otherwise, it's just respecting the fact that there is really differences in the experience of really trying to deliver mental health services, but we have to deliver where the kids and the families are at. And reduce the barriers that already exist with their Black and Brown families. Thanks.
Thank you, Dr. Ng. Yeah, I think you raise a lot of the new barriers we're seeing with this new world, this new remote world. And you actually begin to touch on one of the other aspects, which is, we're moving into remote schooling or uncertainty around hybrid models. And so one of the new challenges children are facing is accessing behavioral health supports that, were in school or still are in schools. So I want to actually turn to Dr. Relaford and see if you could talk some about your work in Sunset Park, as well as your work integrating behavioral health in school settings.
Absolutely. I just want to piggyback a little bit off of what Dr. Ng was saying. I think that immigration-based concerns, particularly in the Sunset Park and Sunset Terrace community, are real. And there were many incidents of families being broken up as a result of fear of police and the similar challenges of police brutality. And so those things are sort of traumatizing families in that setting. A lot of the families are loath, even in this setting, to even come outside because of fear of contracting COVID or even, fear of being accosted. And so I think, we have to really think outside the box. And following up a little bit on what Dr. Ng was saying, you really have to take the care to where the kids are. And I think down in Sunset Park, Sunset Terrace, which is predominantly Hispanic community, but also Chinese community, we've taken the approach. Certainly we have our main clinic that provides care, behavioral health services. We have many therapists, as well as psychiatrists, child therapists. But we've really expanded the work that we've done in the schools. We have 20 school-based clinics, family health center clinics at NYU Langone, Brooklyn, that are affiliated with schools all spread throughout Brooklyn. And what we have is a social worker there who actually provides care in the schools, which is really powerful. Prior to the pandemic, it was literally being where they were. And we worked really hard to actually integrate psychiatric services into those clinics as well. When the pandemic hit, we had to make a big pivot. You know, we were making plans to actually expand telepsychiatry. We had 2 pilot schools in and around Sunset Park, Sunset Terrace, that were very successful in implementing telepsychiatry. And we quickly had to actually pivot to transitioning to telepsychiatry in all of those clinics, as well as our main clinic. That was really successful because what it did was traditionally when the kids drop off from services at the end of school, our school clinicians were actually able to continue work with the kids in the schools, which was really amazing because the kids weren't traveling, they weren't going anywhere, they were still dealing with the same concerns. Summer was a very different summer. And so folks were able to actually receive care. So the school-based model and using telepsychiatry in a hybrid fashion or directly is going to be something that's really powerful. Also, as Dr. Ng mentioned, primary care-based interventions are really powerful for us down in Sunset Park, Sunset Terrace. We've switched to almost a collaborative care model in the pediatric clinic where we've integrated psychologists and psychiatrists into that clinic. Again, going where the kids are comfortable, where they perceive the least amount of stigma. And we've been providing care there and making sure that they have access to higher levels of care if they need it through our main clinic. But I think that's sort of the major aspect. And we're beefing up our initiatives to ensure that we can support our pediatricians who are on the front lines to be able to help them to identify some of these issues. I think for clinicians, being aware of the increased rates of mental health challenges, depression, anxiety, abuse in the communities is something that we can help them with so that we can ask about it, not just about the kids and the adolescents, but also the parents who are supporting them, because if their stress is high, it will make it even more challenging for them to provide adequate care for their children and keep a safe home environment. So I totally agree. I think the traditional models of care delivery are really important, but we've really made a pivot to providing care in the schools, in the pediatric clinics, and really utilizing telepsychiatry, which has been successful to access a larger amount of children, adolescents, and families.
Thank you, Dr. Relaford. And I think that actually brings us really nicely into Dr. Havens, who, we've spoken a little more around the school-age children, but I wonder if you could talk to our audience about the other end of the spectrum on your work integrating behavioral health services and primary care for young children.
Thank you, Allison, and thank you, Dr. Ng and Dr. Relaford. I think just to underscore what we really see happening amongst our very creative clinicians is figuring out how to get to kids where they are and also as early as possible. A lot of kids have problems that start quite young that don't get identified till they get quite old, like teenagers. And as somebody who ran Bellevue's acute care system for 10 years, we really don't need to wait till kids are 14 to help them. We can start early, and probably the most important thing we can do to, in some ways, prevent mental illness is support moms, parents, and very young children. And we're working on an initiative at H&H where we're integrating behavioral health, healthy steps, and primary prevention into women's health when women are pregnant. And we're expanding our screening beyond just depression, looking at ACEs and social determinants of health, and providing community health worker support as well as mental health supports, and then tracking women when they go from women's health into pediatrics for early childhood care, and using the Healthy Steps model, which is a wonderful national developmental support model that's been shown to be quite effective, as well as integrated behavioral health and some other primary prevention. And the goal is to create, and this is actually technically quite challenging, but to create within primary care a 2-generational model of care. We know if moms and parents are really struggling, it affects their ability to provide the most optimal environment for the child. If the young child is really stressful for the mom, that can also affect that. So we know there's a lot we can do in early childhood that has an enormous return on investment. So we're trying to develop and figure out, importantly, how to finance a model of what we call advanced primary care that gives our primary care providers the resources and the clinical expertise in primary care to actually address these issues with moms and their children. So it's really exciting. I think I've learned the hard way that, you can wait too long. It's much more difficult to engage a kid who's 14 or 15, who's been struggling for years. Much better to try to give families the supports they need early on and help with getting the kinds of resources they need to address social determinants of health, dealing with trauma effectively. And we're hopeful that we can figure this model out and generalize it across our entire system and use it as a model for what everybody should be doing in early primary care. And again, I think the theme we're hearing here from all three of us is, while we all run clinical services and we value those clinical services, they're important, but there are also things we can do to get the clinical services out where the kids are and get them there as early as possible and expand those supports to the kids' families. Again, kids only do as well as their parents are doing.
Yeah. Thank you. I think that's an incredibly important point that everyone's been making, is that children are not independent, people on their own. They're part of a family or part of a community, and those things need to be addressed. So I want to move on, and I think more broadly, though these issues are clearly longstanding, we are witnessing greater public attention to the ways racism impacts the many systems that serve families and children. Can you talk about the ways that institutional racism impacts the health and mental health field, and how advocates and practitioners can combat entrenched biases and inequities? And I want to start with you, Dr. Relaford, to see if you can speak some to training needs and approaches in particular.
Oh, absolutely. Not to make this political at all, but, to paraphrase Kamala Harris, implicit bias is certainly real. And I think that is at the heart of thinking of ways of addressing training needs. We've certainly seen in medicine, in pretty much all fields of medicine, that trainees, residents, fellows, as well as attending doctors are all subject to their own individual biases that affect the quality of care that they are able to provide to their patients. And there are disparities there. There are disparities that disproportionately affect the minorities who are actually engaging, from opiate-based care to cardiac care to renal care. All of these things we know are challenges. And I think that's the same approach that we would want to think about and take with our trainees. Now, it's, when you think of implicit bias, it's not something that's a challenge for the individual in terms of on a conscious level. Everyone is subject to the biases that they've grown up in their communities and in this society. And unfortunately, our trainees are also, they're not immune to that. And so the approach is to educate our trainees as well as our clinicians about these issues, about these biases, so that they don't take the approach towards medicine of one size fits all. I think medicine over time has generally taken the approach that we have this particular way of providing care. We're not necessarily thinking about the unique aspects of the patient who's coming towards us. They need to fit in diagnostically, they need to fit in socioeconomically, et cetera. But the approach needs to be flipped. We need to have a patient-centric model that actually looks at the specific aspects of the patient. And to understand that more, you need to be aware of aspects of yourself that may get in the way of being able to see that patient for who they are. So training in implicit bias, which is what we're doing for our trainees, explicitly, but also in just teaching, offering opportunities to be able to explore independently your own individual biases and how they might impact the way that you see the world, see yourself, and see yourself engaging with the care of your patients. And so I think that an approach as such, and not just leaving it up to the beneficence of the individual to do well in terms of the care for their patients, you really have to explicitly go about putting this in the forefront so that it doesn't affect the care that you provide to your patients.
Thank you. Thank you for that. Dr. Havens, I'd like to turn to you and hear from you your thoughts on the professional pipeline and how that's related to equity in care.
Well, first of all, it's very important. One thing that really exacerbates stigma for minority kids and their families is when they go into a clinical care setting and everybody's white. And we have real challenges in our workforce, particularly we have challenges in our workforce, period, getting enough people to do this kind of work, being able to pay them enough. But as you go up the ladder of escalating training, so for example, graduate school in social work, graduate school in psychology, medical school and residency and training in psychiatry and child and adolescent psychiatry, we have fewer and fewer Black and brown people doing the work. And we have to figure out a strategy to address that, because kids need to be able to see mental health professionals who look the same as they do. So really the way we're thinking about this pipeline issue in our department goes all the way back to college, maybe even high school, and trying to engage young people in understanding what the clinical work is like. It's actually very attractive to a lot of young people, and it is a way of giving back and dealing with injustice. The other way, of course, is to become a lawyer, but we're trying to pull people into our way. So, for example, we run an undergraduate minor at NYU, which is a very diverse university, where we teach kids about mental health starting in college. Very, very popular, but exposing kids to what clinical mental health is really about and the various pathways you can take to get there. I think we have to and we are making a very serious effort to increase our recruitment and retention of non-white clinicians on the trainee level, on the medical school level. NYU just eliminated tuition and greatly increased the representation of African-American and Hispanic medical students. So part of it's a class issue, that it costs a lot of money to do these things, and white people tend to have more of the money, obviously, but also it's getting young kids interested in the field and focusing on them and moving them in, and then supporting people of color as they go through their training and mentoring them and making sure the environments that they're working in are supportive and collegial, and working as hard as they can, doing the kind of work that Dr. Relaford was talking about to deal with implicit bias and systemic racism.
Thank you, Dr. Havens. And I think you're speaking to the importance of youth, I think is really a good introduction, because I want to lead into Dr. Ng. And I hope you could speak to how important youth voice is in effective behavioral health care generally.
Thanks, Alice. And I think building off of Dr. Havens' wisdom, I think it's really important that pipeline needs to go back, and it also needs to be much broader than it currently is. So I know that I had mentioned earlier in terms of the American Academy of Child and Adolescent Psychiatry, in terms of our website, in terms of looking at some of these issues. And there's actually a specific video looking at training within child psychiatry, addressing racism and implicit bias, which Dr. Relaford so really lucidly described. But one of the things about youth is that for those of you who have a privilege of working with teenagers and youth, they have a lot to teach us, and they are better versed on issues related to racism and implicit bias and also inequities. And so we just have to do a better job of listening and learning. And I think that in that, it's so powerful to have the youth voice and the empowerment within our behavioral health systems. We haven't done a very good job of having a dialogue. It's sometimes a one-way monologue, where we definitely have to learn more about the youth lived experience. We know how to treat them. Can we actually partner, and can we learn? And so some of the youth empowered programs nationally, such as Youth Move, and for some of the different populations, Jed Foundation for Suicide or Trevor for LGBT, those things are really powerful vehicles for us to really think about how do we galvanize our strength through our collaborations. Some of the things that we've done in Northern Manhattan, we have a program which is the lead agency is The Door. So we have the Uptown Hub. So it's a Northern Manhattan version of really creating a youth empowerment zone, involving youth not only as participants, but actually as program leaders, and in terms of understanding how they can change themselves their peers and their communities. And that's powerful. So a psychologist and associate director for child, R.E.A.L, Chin, who works with me, is really contributing to that with our New York Presbyterian colleagues and team and leadership with Andy Nieto and all. And those are really powerful opportunities to really bring together mental health in a way that's less stigmatizing and more normalizing in terms of youth doing things such as art, music, theater, sports, the things that they want to do. And then, oh, by the way, you know, there's Dr. So-and-so sitting in the corner who's here if you have something else you want to share about that friend of yours that you don't want to talk about, which is often you, but it's often a wonderful euphemism for just creating that kind of space where you can be brave and you can be courageous and actually get the help. There's also the Lang Youth program that we have in New York Presbyterian Hospital, really recruiting adolescents or middle school sort of candidates to really get a mentoring program as well as a learning program to hopefully pursue a career in health and healthcare, which is really important because you have to start earlier. And I think that there's so many barriers, whether or not they're racism or other inequities, that really create barriers to actually getting that higher learning that might be required and necessary to being a mental health professional, as well as just the finances. So I think just really understanding that, but the youth empowerment is really a critical voice. And the UN Convention of Rights for Child asserts that it is a fundamental human right for youth and young adults to participate in designing the programs and policies aiming to serve them. And I think if we were really to really take that on, we would really involve the youth voice in a more meaningful way, but also understand that it's adding much more than what we imagine. And I think that the experience is also giving them power, giving them experience and purpose. We've seen this in our history in our country, the Vietnam War, the Arab Spring, the March for Lives, Black Lives Matters. Youth have a voice that is very powerful, and they speak to each other much better than we can speak to them because, boy, they definitely have the edge on that. But I think they are essential partners in finding solutions. But also, as we're talking about behavioral health and mental health, we also want to be mindful of what they're going through. And this is an incredibly difficult time as a young person to go through this experience. So much like we ask for our Black and Brown colleagues and professionals like Dr. Relford has said, how can we fix this? It has to be more than just adding work to the people who are currently experiencing the most challenges. How can we really think more broadly to be a part of the solution? And we have to do our own learning in order to best do this. So as mental health providers, we have to do our own learning in how to be better youth advocates and understanding how they are a part of the solution, not just the problem.
Thank you. I think those are, great words on the importance of youth, and thank you for sharing your thoughts on that. We're going to have some time, I think, to let you all provide any closing comments you might have, but I think we have a few minutes to just address a couple of the questions that we received throughout the course of this conversation. I want to start with one on the side about telehealth. So the question was, how do you feel about telehealth improving access to mental health services for marginalized people/children? Right now, is it more accepted, but is it more accepted? And how do you feel using this way of treating and accessing more kids and people long-term? So anyone who would like to respond, I'll open up to the three of you.
Sure, I can dive in first. I think that, telehealth has a long history, but it's relatively new in terms of it being so widespread and so broadly used. I think certainly, I've had experience in the middle of that and introducing it, and there certainly was skepticism. And can this care be provided in a way that touches and reaches individuals similarly than to face-to-face? And for what we know that it can, research shows that it does. What's the experience on the part of children and adolescents? The lore is that they probably wouldn't have a positive experience, and actually we've seen that they do. I mean, some of the challenges come up when you're working with younger children who actually aren't so versed in engaging in long periods of time in just conversation. They typically engage in care through play. And so we've had to get very creative during the pandemic to actually do that. And I think that overall, the idea that we've conceptualized down at NYU Brooklyn is not that it would replace face-to-face care, but that it would be a valuable tool for us to be able to reach individuals. Now we've seen, and this is a surprise to us, we were just expecting that implementing telehealth would allow us to be able to continue to provide care and not lose as many patients. But we've actually seen that we've been engaging more patients. And so there's something about the convenience of it, particularly for individuals who have challenges with being able to leave the house, wanting to leave the house, to being able to touch them and engage with them in their homes, which is really something that we've seen has been a powerful thing. Is it going to be perfect? Are there technical glitches? There are technical glitches at times, but I think the benefits really outweigh the risks.
Thank you. Dr. Inger or Dr. Havens, do you have anything to add to that?
I'd just like to, again, thank you, Dr. Relaford. I think that's true. One of the great opportunities of TEL is we actually get into people's homes and see their homes and their families, and that's really powerful. There's nothing like a home visit to learn more about a family. So there's advantages there. It's obviously much easier for particularly people who have multiple children, not to have to schlep them all together to the clinic for one kid to be seen. Again, we have to be cognizant of the digital divide, and the need for privacy is quite challenging for families that are living in very crowded housing, which a lot of our poorer families obviously are in our city. But I think it's a really powerful medium. I think I was on a panel yesterday with someone from the school-based health program up at Columbia, and they're using digital innovation in an amazing way, actually to get into the classrooms that the kids are in and reach kids that way. One thing that we're concerned about as we're trying to figure out how to manage the kids in school is what do we need to do? What kind of innovations do we need to help schools figure out what's going on with kids who they're only seeing remotely, particularly kids they don't know? Because we know teachers are really important and really good at identifying kids who are struggling, both obviously struggling, but also struggling quietly and struggling academically. And what does it look like in a remote world to do that? And I think we need to do some growing and innovation there, just like Dr. Relaford was talking about. How do we work with really young kids? And we're also trying to figure out how to do child-parent psychotherapy, which is a evidence-based intervention for traumatized moms and really young children virtually. So there are all kinds of really interesting challenges. One of my colleagues yesterday was talking about having the kids do dances, so you could take a really careful look at their movements to look for any problems. But I think we're going to really continue to innovate in this area, and I'm pretty sure that we're going to be able to continue, certainly with video, telemental health as a resource as we go forward.
I would love to add to that. I think it's really a wonderful, I think with Dr. Relaford and Dr. Havens, this is an opportunity, and this is a new world in terms of being able to access folks. The digital divide does exist, but also not all children benefit from tele. So some children really need that in-person experience. Children who are on the spectrum, children who might have other issues, or even as we spoke earlier in terms of the decrease in terms of child abuse reporting, some kids we have to see for safety reasons. And part of that reason is really to appreciate their whole experience. I love the video home visits, Dr. Havens. I think that whole idea of sanitizing a home, making sure that this home is safe for youth and adolescents is really important, and understanding who's actually there, who's in your world, what is your world. And I think it's really created some unique opportunities to do that. And I think that we'll continue to learn. I think, as Dr. Relaford said, this is relatively new, but the possibilities might be endless, and we should definitely explore that, as long as those billing mechanisms and OMH regulatory approvals continue to be supportive of an innovative model. We still have to understand what is best for kids and adolescents. Just because it's easy doesn't mean it works. Just because it's easy doesn't mean it's good. So I think we have to really hold ourselves to our feet to the fire to understand what is impactful, what is meaningful, how can we increase equity, how can we increase access. So I think those really are important questions for all of us.
Thank you, Dr. Ng. I think we probably have time for maybe one more question, but just to also make sure that we give you all opportunities to raise any final, issues you might want to share with folks. I'm going to combine this and see if you have a response to this question, please share it. And if you have any sort of final thoughts, please also feel free to share those. So we have a question, given significant increase in substance use, if during the course of providing mental health services and substance use issues become evident in young people and parents or caregivers, how well are your systems positioned to respond to the need for substance use treatment and support? So I'll just open up whoever would like to start.
I'll take the first try. Most kids with substance use problems, the vast majority of kids with substance use problems also have mental health problems. And I would like to think that we are not victimized by the historical divide that said if you have a substance use problem, you have to go get your substance abuse problem treated before you can get your mental health treatment. No child clinician worth their salt should think that way, because they tend to be very closely integrated. We do have a lot of resources in New York State for parental substance abuse. We're also making enormous progress in medication-assisted treatment for opioid addiction, also for alcoholism. So, I mean, parental substance abuse is one of the adverse childhood experiences, and it is something we are often dealing with our families. We've learned the most effective approach is a harm reduction approach, where you engage people and help them begin to think through where they are and their readiness to change and be open to that. So I think we've integrated that into our work as child and adolescent clinicians, and that's essential. My closing remark, I just like to say the thing that I've been fighting for my whole career, and we need to continue to fight for, is to get more resources into the child and adolescent mental health system. We spend a lot of money on sick adults, which is appropriate, obviously, but I think if we spent more of our money on prevention and keeping kids who are mentally ill well, which palliates the functional impairment of mental illness, we would have less sick adults. And that's really a very important advocacy area. I know the Healthy Minds, Healthy Kids campaign that CCC is running is really pushing this, but I want to encourage everyone to get on board with that kind of advocacy.
I can dive in next, and first I want to say this has really been a wonderful experience, and I like Dr. Havens mentioned, am the fortunate recipient of having, these two great mentors, Dr. Ng and Dr. Havens, who've actually guided me as a Black male in sort of some of these challenging experiences and sort of navigating the medical world. With regards to substance abuse and adolescence, I think that our clinicians are all trained to be able to identify and work with kids and adolescents who have maybe a mild to moderate level of impairment. And like Dr. Havens said, it should not be segregated in the way that, if there's a substance abuse issue, then you automatically ship them off. You need to assess it, and we train our clinicians to assess it and to be able to identify if it's a more serious issue that needs additional level of specialty care. So I think that certainly all the clinicians that are at NYU Manhattan, NYU Brooklyn, they're certainly on the lookout for that and are able to work with it in sort of more mild to moderate parameters.
Thank you. And Dr. Ng, do you have any final thoughts?
Sure, and I'm so grateful for this opportunity. Thank you so much to Alice and CCC and the leadership to really put this dialogue together. I think my first job was the one given by Dr. Havens, so at Columbia. So I think that what I learned from that is a lot, but one of the things is that it was a treatment program that treat parents as children in the same place. And I think that there is a divide when we think about our systems of care, whether or not it's substance use or mental health or adult and child. And I think that that's a real disservice for the kids and the families that we're serving. So understanding that substance abuse and substance abuse vulnerability is heritable. So it's a family and intergenerational experience. And so when we're trying to find solutions, we need to think more broadly to really focus on the whole issue. And so that's really a family experience. And I think that Dr. Havens' comments about really creating models where you do two generations at a time, those kind of interventions are very powerful. So I really want to echo, how can we look at our silos, break them down, serve the kids, serve the families, and really focus on where the solutions can be. And I do want to echo your comments also in terms of, as I mentioned, 50% of all adult mental health conditions start before the age of 14, 75% before the age of 24. If we did a better job of addressing sort of earlier on, how do we take care of these kids? But I also want to echo, it's not just prevention, we need higher intervention treatments as well. We need the whole spectrum, but hopefully over time, if we do a better job with prevention, we'll have less of a need for more intensive treatment. But right now we're not at that point. So we have to support the whole spectrum, but also in terms of informing our process, involving the voice of the kids and the families and the communities of color so that we can be most respectful with cultural humility and to be most impactful overall.
Thank you, Dr. Ng. I think those are really excellent words to end on because we are at time, and I just want to thank you all so much for participating today. I think this has been a really wonderful and helpful conversation. I hope our audience has found good value out of it. So I also just want to mention to the folks listening that we hope you can take a few minutes to fill out a survey we have about this event. It should be in the chat box. You can also find a link there with information about the next events in the R.E.A.L Talk series. And that, this is a collaboration with CCC, FPWA, and United Neighborhood Houses. Again, we hope this discussion has been really helpful to you. As in previous sessions, we urge you to keep talking, learning, and pushing for equity. Please remain in touch with CCC and our partner organizations, UNH and FPWA, in the weeks and months that follow. And thank you again so much to our panelists for your time and for your dedication and your work.
Thank you.